Okay.
Thank you,
We're
Lindsay.
recording. All right. All right. As Kristen said, I am a nurse practitioner. I work at the Mercy Center for Memory Health. I've been here for a few years now. We're growing, and we're excited to educate more people on what dementia looks like and decrease some of the stigma that is surrounding this diagnosis. So my objectives today is I'll talk about why it's important for someone to obtain a diagnosis, describe to you what dementia may look like, what symptoms that they might start experiencing, discuss different forms of dementia, and then we'll also explore some of the non-pharmacological treatment options. I'm going to skip medications today because that can be an entire presentation of its own, depending on what symptoms somebody is experiencing. So we'll start with why a diagnosis is important. Early diagnosis of cognitive decline leads to earlier treatment. And as with any disease process, earlier treatment always leads to better patient outcomes. To start, we'll look at what dementia could look like. And there are 10 major signs of dementia, and we can get out a flyer to anybody that might want one. It's available on Mercy's website as well. This just kind of talks through when things might be normal versus when they could be something that we should look at a little bit further. If you are experiencing any of these signs, it doesn't mean that you are experiencing dementia. It just means that the way your brain is processing information has changed slightly, and it might not be a bad idea to talk to your primary care provider or just be evaluated by a specialist as well. So memory loss that affects your daily life can be concerning. If you're just forgetting people's names once in a while or an occasional appointment, that can be normal signs of aging, challenges in planning or solving different problems. This includes inability to follow a plan that you have set forward, or trouble paying bills or cooking recipes. Difficulty performing familiar tasks, some confusion with time or place. And I'm not going to read all of these in detail. Like I said, they're available online, that we can always follow up with the email as well with this if anybody would like. Changes in vision. This does not mean cataracts or if you've had vision problems in the past, but this really looks more at whether we're having difficulty reading or staying on the same line when you're reading, determining color contrast, judging distances. Sometimes what we'll see is that people are tripping over things more often, they're spilling, dropping things. Communication issues is another one. Sometimes it's common for all of us to forget the right word at certain times in your conversation. But if you're having more difficulty initiating conversation or following, that's a little bit more concerning. It's also pretty common to misplace items, but if you're able to retrace those steps, that's a good sign. If you're retracing those steps and you're finding them in weird places, like the car keys in the washer, the dryer, the refrigerator, or finding refrigerated items in the cabinet, that's a sign to have things looked at a little bit more closely. Decreased or poor judgment, frequently or paying less attention to your own physical appearance can be alarming. Social withdrawal, so not initiating activities or going out like you've always once done, and then any major changes in mood and personality. So that doesn't mean that you're situationally sad about something or that you're a little bit moody, like if you didn't get enough sleep the night before, but if you're having rapid mood swings, maybe just talk to somebody about that. So we'll touch briefly on the diagnostic approach that we use at the Center for Memory Health. We always gather a comprehensive history. We are assessing for different changes in cognitive capacity, do some cognitive testing, obtain important labs, and then also discuss whether or not head imaging needs to be done. Oh, I'll go back. I'll elaborate a little bit further. So that comprehensive history is going to look at whether or not somebody is capable of doing activities that they once were capable of doing. Are they we'll look at the medical history, your surgical history, all of the medications. We have a pharmacist who will review all of the medications, look at the different interactions, potential interactions between medications. address your sleep, mood, balance. The cognitive testing takes about 15 to 25 minutes during that initial appointment. And important blood work could include just looking at electrolytes, overall blood counts, vitamin B12, your thyroid level, and a few others depending on what your medical history includes. I'm going to touch on mild cognitive impairment, and this is when somebody is experiencing some memory changes, but it is not actually interfering with their capability to function in their daily life. So they might have, or they do have, a decline from their previous level of cognition. Sometimes they experience issues with memory loss and sometimes some instrumental activities of daily living, which includes maybe missing some medications once in a while, making an occasional error on their checkbook, but they're generally able to compensate for those changes. It's not alarming to themselves and usually not really alarming to people around them either. Dementia is actually not a true diagnosis. It's really this umbrella term. It's a syndrome that's characterized by a decrease in cognition, which causes the impairment of one's activities of daily living. And it may also cause some behavioral problems or changes. And that's some of the stuff that I had talked about on those 10 signs. The most common forms of dementia include Alzheimer's disease, vascular dementia, dementia with Lewy bodies, and frontotemporal dementia. It's important to note there's over 100 different forms of dementia out there, but these are the most common, and it is also common that you can have more than one disease process present in the brain at one time. So in the beginning stages of dementia, it's not always clear exactly what form we might be experiencing. So we're diagnosing on a clinical level, meaning we're addressing the symptoms that somebody is experiencing and making a very educated judgment on which form that they're probably experiencing. So Alzheimer's disease is that most common form. It accounts for anywhere from 50 to 75% of all cases of dementia. It's caused by plaques and tangles that start to build up in the brain. And when they build up, different parts of the brain experience some atrophy or shrinkage due to the proteins. Those cells end up dying. We normally see a gradual onset of the symptoms over several months or possibly even several years. The most prominent complaint that we hear in Alzheimer's disease is that our memory just isn't what it used to be. And the biggest two risk factors for Alzheimer's disease is a strong family history and then also increasing age. Vascular dementia is the second leading cause. It is the risk factors there include the stroke, diabetes, uncontrolled hypertension, high cholesterol, and I don't have them put on here, but also a history of smoking and then chronic alcohol consumption also can play into it. If somebody has had a clinically apparent stroke, that the cognitive decline occurred abruptly after that, that does help guide us down the path of a vascular dementia, but we also take into consideration those risk factors that I had mentioned. And then the symptoms of vascular dementia vary greatly based on where that stroke has occurred in the brain. Dementia with Lewy bodies is a little bit less common. It is caused by the presence of protein deposits that are called Lewy bodies. Diagnosis requires two of the three following symptoms: fluctuating cognition, recurrent visual hallucinations, and then some Parkinsonism, which is slowed movement, some balance difficulty, muscular rigidity, and then a tremor. Oftentimes, these patients also have a REM sleep behavior disorder that is characterized by some thrashing around in the sleep, vivid dreams. Sometimes the person they're sleeping in the same bed with reports that they've actually been hit or they've fallen out of bed. Just a major disruption in their sleep cycle. Dementia with Lewy bodies is actually the type of dementia that Robin Williams was diagnosed with. I don't know if anybody was following along with that story. It's actually the same protein that builds up in Parkinson's disease. And so this is kind of what happens when we start to notice the cognitive changes that also may occur. And frontotemporal dementia is less common, but definitely worth mentioning here. And this is caused by some atrophy of the frontal and the temporal lobes. There are 3 variants of frontotemporal dementia, behavioral variant typically being the most common form of that one. And that involves changes in a person's personality, behavior, and judgment. There's also primary progressive aphasia, which is defined by changes in the ability to communicate, whether that is finding the correct words or being able to interpret what somebody is telling you. And then there's also movement disorders, which are very rare. And they require a neurologist to look at these patients and to diagnose. Mixed dementia is when there's more than one type of dementia present. This is especially common in patients who are aged 80 or above. As I said, it's not always obvious in the beginning stages as to which type of dementia it might be, because sometimes the symptoms overlap between the different forms. And if you do have more than one form of dementia, we are more likely to see a quicker disease progression than if there was only one form there. So non-pharmacological treatment, we always try to address the lifestyle risk factors, and I'll go into this a little bit more in depth on the following slides, but if people are willing and able to adopt 2 to 3 of these changes, it can reduce their risk of developing dementia by up to 37%, and studies show that if you can adhere very strictly to all of these, it can reduce the risk by up to 60%. Once people are evaluated in the clinic, we determine where their strengths and difficulties lie, and then we make appropriate referrals. Some of those can include physical therapy, occupational therapy, and also speech and language therapy. And then another big focus that we have in the Center for Memory Health is that we continue to care for the care partner and support them, because this can be a strenuous change for everybody's, because it can be a little disrupting for their lifestyle. So those lifestyle factors that I talked about include nutrition, physical activity, cognitive activity, decreasing alcohol consumption, and also smoking. Nutritional importance, it's important to adhere to a healthy diet. We typically recommend the MIND diet. It's the Mediterranean and DASH intervention for neurodegenerative delay. It has a list of 10 brain healthy foods and then also 5 not so healthy foods. If you do follow this diet, it can decrease the risk of developing dementia by up to 53%, and it can also help to slow the progression as well. One easy way to look at this is to avoid the processed foods, try to eat as much fresh food as possible. Getting physical exercise is really important. We recommend getting moderate intensity exercise, 30 minutes a day, 5 times a week. What this does is it increases the blood flow to the brain, which has obvious benefits there, and then it also decreases the inflammation of the brain. One way to know if you're getting moderate intensity exercise is to practice the talk test. So if you are exercising, you should be able to have a normal conversation with somebody and not feel too winded. However, if you shouldn't be working out so lightly that you're able to sing a song. So just keep that in mind while exercising. Cognitive exercise helps people to compensate for the damage. So all of us start with the same amount of brain reserve. That's the physical size of the brain. Like I explained with all the different forms of dementia, we start to see different areas of the brain be affected, and that can cause some shrinkage in those areas. And the cognitive reserve, though, is different for everybody. So that's in the way in which your brain can work around the changes. And we know that you're able to build more cognitive reserve by keeping that brain active throughout your entire lifetime. Decreasing unhealthy habits is very important as well when talking about the treatment and prevention of cognitive changes. Excessive alcohol consumption can lead to eventual brain damage. It is okay to participate or partake in some alcohol consumption if you're doing light to moderate usages. Smoking cessation is always important. If you are a smoker, it does increase risk of developing dementia by up to 45%. That is not just for the vascular forms, but it's also for Alzheimer's disease as well. Estimating up to 14% of all of these cases could be linked to smoking as well. Next, I'll talk about appropriate referrals with physical therapy, occupational, speech language pathology, and then I'll also touch on the Family Caregiver Center of Mercy. Physical therapy has huge benefits, not only for the physical standpoint, where we'll address the balance and gait stability. This will tremendously reduce the risk of falling or significant injury. That's very important because we know that anytime somebody sustains a major insult to the body, whether that's a physical insult or a emotional insult to the body, that tends to decrease their overall cognitive abilities. So that's sometimes where we see a dip in their cognition, a little bit quicker progression of the disease process. Physical therapy will also increase circulation, which is good for overall health and increased cognitive ability. It'll also increase the amount of socialization that somebody gets because it's having them get out into the community, meet with another provider, focus on different aspects of their life. And any form of physical activity also has a direct association with stress reduction. Occupational therapy has a couple of different roles. We use them often to evaluate for safety. They are able to help us with driving safety evaluations and treatment. So driving is a hot topic sometimes in the clinic because it gives people a sense of autonomy. And when we say it might not be safe to drive any longer, that can be really difficult to overcome. So if we can send somebody to the right therapy to help improve on their skills, it's very value added. Occupational therapy is also known to do a very comprehensive home safety evaluation, and that's important because most people want to remain in their homes as long as possible, and that's our goal as well, as long as things are safe. They can also work on improving those activities of daily living and also with functional mobility, so they can help provide supports that can be put in place in the home, and they can work on adapting for the changes that somebody is experiencing and also help find ways to compensate for those changes. I think speech therapy does a really great job at helping us out and providing so much support for patients as well as the care partners. They don't work with just speech. So I think that's the biggest hurdle sometimes to getting people to buy into that speech therapy referral that we often send. So sometimes in dementia, people might experience more difficulty with expression or reception of words. That makes it more difficult to follow conversation or to comprehend questions that people are asking them, but they can also help provide strategies for memory and just to help with conversational improvement. They'll work on cognitive function as well. They can come up with activities that'll help work different parts of the brain and help compensate for the changes as well. Late in the disease process, we do sometimes see difficulty swallowing, and so they can do swallowing therapy, which will provide strategies for safe eating. So that's incredibly important because we want to make sure that everyone is still getting the nutrients that they need, and that includes not just food but also fluids. We have seen that getting people in for swallowing therapy also decreases the stress during meals for not just the patient, but also the care partner as well, because oftentimes people are concerned that they might choke on the food. And so that tends to decrease our, the nutrition that we're getting. And then they can also help provide care partner education and support. Oops. And then as far as continued care partner support, we are very focused on the well-being of the care partner. Caregiving for anybody with a chronic disease process can be exhausting at times, very rewarding, but it also can create some strain for that person who's providing the primary support. So things that we're really monitoring for here in our clinic is depressive symptoms. Are they experiencing some caregiver burden? We want to make sure that everyone is still doing some self-care activities, make sure that they've got social support as well. So oftentimes, if somebody is experiencing a heightened amount of caregiver burden or any of these other symptoms, we'll try to get people from the Family Caregiver Center of Mercy involved. And when we're able to do that, we've seen that people have a better sense of community, and that really helps them be able to continue to care for that person living with dementia much longer.